talk like maybe my grandfather should have given in the early 70s, how to set PEEP in ARDS. Here are my links of interest. And so the topic is how to set PEEP in severe ARDS. So my mindset that severe ARDS is, according to the Berlin definition, PO2 FO2 ratio below 100. I'm not sure this is a good definition because looking to different phenotype with the same PO2 FO2 ratios, the mortality is absolutely not the same. But we will discuss according to the severity. What about guidelines on PEEP setting in ARDS? I was yesterday in this fantastic session on new guidelines for ARDS, and Giacomo Grasselli clearly tell us that they were not able to give recommendation on PEEP setting for severe ARDS patients. It's a shame, but today the literature do not give us the opportunity to give recommendation on how setting PEEP in severe ARDS patients. What is sure today, if we go back to the early beginning of ARDS, is that if you do not use PEEP, all the patients die. Everything was right in this paper in the 1967, that we are not sure that giving PEEP saves all life, sure not, but if we don't use PEEP, quite all the patients die. But it's not enough. What is the state of the art according to the PEEP titration in ARDS? 3 old trials comparing different ways to set PEEP. The alveoli trial comparing high PEEP and low PEEP according to the PO2 FO2 table. The LOVES trial, quite the same design on the PO2 FO2 table PEEP setting, and more or less recruitment maneuver. And in both cases, there was no difference in terms of mortality. You use high PEEP table or low PEEP table, the result was the same, only the age change in the alveoli trial. And the third trial is probably not the same, the French trial from Alain Mercat, comparing a low PEEP strategy, minimal alveolar distension using a PEEP between 5 and below 10, and maximum alveolar recruitment. It means that you put a tidal volume of 6 ml by kilogram of ideal body weight and increase PEEP to reach a plateau pressure between around 30. The results were negative in terms of mortality, but the time spent on mechanical ventilation and the complications related to mechanical ventilation were lower in the high PEEP strategy. But putting all these results together, there's quite no changes in the outcome according to the PEEP setting in severe ARDS patients. So maybe we should stop the discussion about what randomized controlled trials give us as answer for PEEP setting and just be agree with the guidelines, say that we are not able to give recommendation according to the evidence-based medicine for PEEP setting. But we all of us are working in ICU and we can say to our patients that we have no guidelines. So we need to set something in the ventilator and maybe we should go back to a physiological approach for setting PEEP in all patients because we need to do something. So I love this paper on the holy grail of setting PEEP in ARDS. At the beginning, setting PEEP was essentially a matter of oxygenation in the early 70s, really early 70s. But quite quickly, with this paper from Peter Sutter, we all understood that oxygenation was not everything in terms of setting PEEP. Oxygenation and lung and chest wall compliance were not the only important points to look at. Maybe hemodynamic and oxygen delivery were also important. And it was the concept of best PEEP, the maximum PO2, the maximum compliance with the good oxygen delivery. And this best PEEP was not the higher PO2, the higher compliance. It's a compromise between oxygenation and oxygen delivery. I'm not sure we have done really better in the last 45 years. But it was one step. To move on, we understood the need of a compromise and tried to adapt the PEEP according to mechanical property of the lung and the chest wall. And it was the time of a pressure volume curve. And we have a lot of hopes on a PV curve to help us to set PEEP. The shape of the PV curve on normal subject, on ARDS subject, or COPD subject were not the same. And we hope that setting PEEP just above the low inflection point, it means the time when the lung opened, was a good way to set PEEP. We were quite disappointed because it's not so simple. The model is not so simple, and we have lung collapse just above this point, and we have lung hyperinflation just below the upper inflection point. So a good physiological concept that makes sense to analyze the property of the lung, but probably not the holy grail to set PEEP in our patient. But why are we using PEEP in ARDS patient? That's probably the question we have to keep in mind. Not to open the lung, but probably just to keep the lung as open as we can. And this is important at each step to understand that this is a question of compromise. And the compromise between hemodynamic and oxygenation is, I think, clear for everybody in the room and in all ICU in the world. Probably what we have to keep in mind is the compromise between alveolar recruitment and hyperinflation. If we increase PEEP really high, 40, 50, we can open all the lung. It's not a problem. It's just how much we pay in terms of hyperinflation, inflammation, and hemodynamic instability. So we have to look at what is the balance between alveolar recruitment and hyperinflation. Here you have the Huntsville unit. This is CT scan of different patients. And here the poorly and non-aerated lung region. Here is the normally aerated lung region. When we move from ZIP to PEEP, we put a lot of gas in previously healthy lung region. It makes no sense. It's not dangerous, but it makes no sense for the patient. It's not interesting. If we put some gas here, above minus 900, this is hyperinflation. Probably it's harmful for the lung. In the non-aerated and polyaerated lung regions, when we put some PEEP from 0 to 15, we put some gas and switch non-aerated lung region and polyaerated lung region to normally aerated lung region. Alveolar recruitment is just this part. It's only this part, putting gas in non-aerated and polyaerated lung region. That's probably the aim of setting PEEP, keeping this part of the lung open. This one is not so interesting. It's not dangerous, but it's not the aim of setting PEEP through our patient. So how to set PEEP in this idea? Here you have the PO2 FiO2 table, and I spent years and years to say that it was not interesting. It's not physiologically sounding well to us because it's just PO2 and PEEP, not so well linked. At the end of the day, after 40 years of research, it's not so bad. It's not so bad, and probably when we are not sure about what we are doing, using PaO2 FaO2 table is not the wrong solution. The express method, increasing PEEP to reach a plateau pressure around 28 or 30, is probably quite interesting. If we look to the results of the lung-safe trial, a lot of our ARDS patients are not in this good way to set PEEP, whatever the method you use, express or PaO2 FaO2 table. To move on, maybe we can use a driving pressure. Driving pressure is really simple, but it's nothing more than the compliance related to the tidal volume. But it's simple. And all the residents in my ICU are really familiar with the driving pressure, and everybody talks about driving pressure. So maybe this is a good help. Setting PEEP, performing a PEEP trial, and looking to the driving pressure. It may be a good compromise to achieve the good PEEP to our patient. The transpulmonary pressure is probably more interesting on the physiological point of view, and looking to the data from the group of Boston, of Danny Talmore, it makes sense, because it gives us the opportunity to choose a good PEEP according to the chest wall and lung compliance of our patient, and it's quite clever to setting PEEP. And you see, comparing to PEEP FaO2 table, in some patients you increase PEEP with esophageal pressure, in some other you decrease PEEP. So I think it's interesting. But when we try to use that in a large randomized controlled trial, the results are absolutely negative. It means that it's difficult. And it's probably too difficult at bedside for all our severe ARDS patients. Another possibility is to try to put all our knowledge together. I picked this slide from Hope paper published in Critical Care this year and change it a little bit. They said that first we should intubate the patient and look to the PEEP tidal volume according to the guidelines. Maybe we can add a little added value, will be to use CT scan or ARI ratio just to have an idea about the recruitability of the lung. If the patient is focal or with a low ARI ratio, maybe using low PEEP. And after, probably what we need is to take into account driving pressure, mechanical power, and lung imaging at bedside to just be sure that we put the PEEP on the good way. There's no proof of that, but I think it makes sense to use that. We need tools if we want to do more than the PaO2 FaO2 table. We need tools because lung morphology, low inflection point, etc., just give us a trend in the recruitability of the lung, not the level of the PEEP we need to put. And Laurent just gave a few results of the lab trial. Just look at that. When we do something else than the PaO2 FaO2 table, if we are wrong, it's dramatic. If we use high PEEP, recruitment maneuver, and low tidal volume in patients with focal lung aeration, it's dramatic. If we use low PEEP in a diffuse ARDS, it's not so good. And in any case, this is my main message, this is worse than PaO2 FaO2 table. If we set the PEEP properly according to this methodology, it's better than PaO2 FaO2 table. But if we are wrong, it's worse. So be careful with PEEP setting in ARDS. So to conclude, unfortunately, today we have nothing more than physiology to try to adapt the PEEP to our patient. We need tools. We need to titrate the PEEP and to reevaluate every day, every hours at the early phase, the PEEP level to our patient. I don't know it's going to save a lot of lives, but what I'm sure is that at the time where more and more physicians in ICU are subject to burnout, trying to find the holy grail of setting PEEP is good for our mindset and for our brain. Thank you for your attention.
Thanks a lot, Jean-Michel, for this wonderful presentation. Are there questions from the audience?
They are trying to find the Holy Grail.
And maybe to start, I have one. Very practically at the bedside, which tool do you use when it's complicated?
First, I do something like the Express to set the basic PEEP. After, we use more and more EIT to look at what happened. In my ICU, we have a long experience of lung ultrasound, but it's time-consuming, it's a little bit boring, and even the young are not so comfortable, and I'm not sure about what we see. Maybe there's a little part of subjective. EIT is quite simple. I don't know if it's perfect, but it's a kind of GPS. Not so different from a GPS, and moving from de-recruitment to hyperinflation. I'm not sure I am in the good position. I'm sure I'm not in the wrong, at least.
But, I mean, let me be provocative. I mean, you don't have a single slide on electric impedance tomography, but that's what you use on your clinical practice. I mean, give me the context for this.
Because it was not the title of the topic. We have absolutely no proof that it can save life. Maybe it's not so different from the PV curve or from the CT scan. It's just disponible at bedside, easy to do, and it gives you trends of change in lung aeration. This is no more than changes in lung aeration, but I think it's helpful. I hope it's helpful.
But you still hate the PEEP FiO2 table. I mean, that's your reflex. I mean, make a public confession. I don't support American data. I mean, that's...
Do you know why I put the slide on a PiO2 FiO2 table? Because 15 years ago, I presented the first result on lung morphology, and you tell me this is worse on PEEP and FiO2 table. So I say I need to put the slide of PEEP FiO2 table. But at the end of the day, it's not so bad.
Maybe a question here?
Antonio Pesenti from Milan.
Do not present yourself, it's not necessary.
I want to be provocative.
Like every time.
I'm going to say a crazy thing. 80% of our ARDSs are pneumonia. And if we have lobar pneumonia, we do not use PEEP if we have one single lobe. If we have 3 lobes, perhaps. So why do we use PEEP? To improve oxygenation or to expand the lung? Because then we should expand the lung also in lobar, single lobe pneumonia. Is it it's just to provoke?
No. Can I be provocative in my answer? I think ERDS do not exist. This is just the severity of the patient. And when the patient is really severe, you have lung edema due to inflammation, not to pneumonia. And we just deal with the part of lung edema, absolutely not with pneumonia. You're right, Antonio.
Okay, we have to move on.